Ankurji, are we live?
We are on live. We are live now, but let me check in just last 10 seconds more, please, sir. But we are on live. But I'm checking in the website. Yes.
Okay.
Yes.
Sir, it's 5:59. Should we start?
You can start.
Okay. Right. So team, we are starting. Okay. So very good evening to all of you. I hope that everybody is safe and everybody is at home currently in the pandemic situation. First of all, on behalf of Curis Mankind Specialities, I would like to welcome all our participants, all the attendees that are attending this program via digital platform of Netcast. It makes me, immensely proud, and today I am really happy to bring on board one of the leading experts in cardiology from South India, Professor Dr. M. Chenniappan. On behalf of Curis Mankind Specialities, sir, I welcome you. I welcome, sir, to have this very interesting talk on target-specific oral anticoagulants beyond AF, in especially with the aspect of usage of anticoagulants. Dr. M. Chenniappan, sir, is a DM Cardiology, Senior Consultant Cardiology at the Ramakrishna Medical Center in Trichy. And, it gives me immense pleasure to invite him to, for this talk, for this insightful talk.
Hi, Arvind. There be apna tha na?
Okay. We can, over to you. And, thank you so much.
Thank you. Good evening, everybody. I thank Mankind for giving me this opportunity, especially the Curis Pharma to give me this opportunity to talk to you on a different topic, topic which is not often discussed. So many times we talk about target-specific oral anticoagulants. We always talk about atrial fibrillation and its indications, and which is the best among these three target-specific oral anticoagulants. I thought I will look beyond atrial fibrillation for the use of target-specific oral anticoagulants, especially in the segment of what is now known as chronic coronary syndrome. So I'll start with the three patient scenarios who had the chronic coronary syndrome clinical scenarios. The 65-year-old, 10 years post-myocardial infarction patient, completely asymptomatic, on standard of care therapy, including aspirin, statin, and so on, antihypertensives, and so on. 10 years post-MI, who was completely stable and asymptomatic, develops sudden ischemic stroke and becomes bedridden. And the second patient is non-post-MI patient, a stable coronary heart disease patient, who is once again with multiple risk factors, but completely asymptomatic. A patient who has stable angina, multiple risk factors, suddenly develops acute coronary syndrome. And next patient is 60-year-old post-MI patient with peripheral artery disease, develops acute limb ischemia and loses a limb. Although all these patients were post-MI, a stable CAD, and the patient with the post-MI and PAD, all of them were stable and asymptomatic on standard of antiplatelet therapy like aspirin and statins, anti-lipid therapy, statins and statins and so on. In spite of all this, these patients landed with three different problems of acute problem in the heart, acute problem in the brain, and acute problem in the lower limb. So my talk is going to be entirely based on how to prevent these type of events in patients who are supposed to have a stable coronary heart disease patients, or patients who are very long duration after a first or second myocardial infarction, and people who have a polyvascular problem along with the coronary heart disease. So my talk is going to be focused on how to prevent these very dangerous as well as very decapacitating symptoms or diseases in patients which are called who are called as stable coronary heart disease patients. This is my plan of talk. First of all, we'll first learn about what are Tosacs. Although previously they are called novel oral anticoagulants, the better term today will be they are no longer novel because they are existent in the market for so many years now. So we'll call them as target specific anticoagulants. I'll come back within a minute. Just I'll reload and then come back. So no longer they are called novel anticoagulants, and today they are called target specific anticoagulants because of they are no longer new anticoagulants now. They are now actually there in the market for more than 10 years or so. That's why now we call them as the target specific oral anticoagulants. I'll define what is target specific anticoagulant subsequently. So that is my first area of my talk. So for that, we must understand the coagulation pathway. As you know, whenever there is a discontinuity of the endogenous blood vessels or the exogenous blood vessels, the coagulation system come into play to produce a clot and seal that particular break in the vascular system inside or the vascular system outside. So intrinsic pathway starts with factor 12 and extrinsic pathway starts with factor 7. Ultimately, their job is to convert the factor 10 into factor 10A. Whether it's intrinsic pathway or extrinsic pathway, they come and end in factor 10A, converting that into 10A. So the 10A is the one which converts the prothrombin into thrombin. And the thrombin is going to do two things. It is going to convert the fibrin to fibrinogen to fibrin. And also it is going to activate factor 13 to produce a stable fibrin clot. So this is how this is a final common pathway. So this is how the final common pathway, irrespective of this extrinsic pathway or intrinsic pathway, they all end in factor 10A and they convert the 10 into 10A. So when we say the oral anticoagulants, we always think of vitamin K dependent oral anticoagulants such as coumarin and warfarin. And coumarin and warfarin are going to work on those clotting factors which depend upon vitamin K for their formation. So that's why they are called vitamin K antagonists. They are factor 7 and the 9, the factor 10 and factor 2. So these are the factors. There are multiple factors. The vitamin K dependent coagulant factors. They are vitamin K dependent coagulant factors. So whenever you use coumarin or warfarin, which is going to block the vitamin K, are going to block these coagulant molecules or coagulant factors and then prevent clotting and thereby resulting in anticoagulation. So they are now, because they are acting in multiple coagulation factors and they are acting against vitamin K, they are called vitamin K antagonist. Whereas when you look at target specific oral anticoagulants, the target specific oral anticoagulants are going to act on a particular coagulant factor. The coagulant factor, two important coagulant factors, but at this point in time, we are going to talk about only oral anticoagulants. So I'm not going to discuss about the parenteral anticoagulants. As far as the oral anticoagulants are concerned, we have already seen vitamin K is going to act on multiple factors, whereas target specific oral anticoagulant, you can see that vitamin K antagonist is 2, 7, 9, and 10. And that's why these coagulation factors depend upon vitamin K for their formation. Whereas when we say target specific oral anticoagulants, they are going to act on a specific factor. So there are two specific factors these drugs are going to act. Target specific or Tosacs are going to act. One is 10A. They are going to block 10A, and those drugs are apixaban, taraxaban, edoxaban, and rivaroxaban, or 10A inhibitors, and they are direct 10A inhibitors. So they are anti-10A factors. Whereas the oral thrombin antagonist is dabigatran. Zimalda is another one, but well-known Tosac is dabigatran. So oral thrombin inhibitor is dabigatran, and direct 10A inhibitors are going to be apixaban, edoxaban, rivaroxaban, which are available for our use. So when you look at Tosacs, they are specifically either acting on 10A, which could be rivaroxaban or apixaban, which is clinically we are using now, or they are going to act against thrombin, which is dabigatran. So that's why, because they are going to act against a single coagulation factor, they are going to target one single factor. Now they are called direct or the target specific oral anticoagulant. That's why it's called TOSACs. They are better called as TOSACs. So having understood the TOSACs, now we should answer the question why we should switch over from warfarin or a coumarin, vitamin K oral anticoagulants, which we were using for so many years, to the newer TOSACs. What is the purpose? So whenever we use the vitamin K antagonists such as warfarin, there are a lot of disadvantages. One, they have a very slow onset and offset action. That means if you start a drug, it takes 3 days for the drug to act. And if you stop the drug, it takes 3 days for the drugs to go off from the system. There are numerous food and drug-to-drug interactions. There is a huge risk of bleeding complications. They have a narrow therapeutic window. You have to keep the INR between 2 and 3, and you have to routine monitoring is needed. Every 1 or 2 months, we must be keep on seeing the prothrombin time and INR. And many patients are the patients himself, intra-patient and inter-patient unpredictable response is there. And that's why we have to do a frequent dose adjustments. And warfarin was number 1 in the number of mentions of deaths for drugs causing adverse effects in therapeutic use. So they are supposed to be very, very narrow therapeutic window. So they cause so many problems. And of course, the adverse drug events are going to be very high, which will require hospitalization. So that's why these are the disadvantages of well-known vitamin K antagonist. And the most important point is, remember, we are giving oral anticoagulant to prevent thrombosis. So at the same time, we should not land up with the bleeding. So there's a delicate balance between the thrombosis and bleeding. So the vitamin K antagonists such as warfarin and coumarin have got narrow therapeutic window. You will be having the best anti-thrombotic effect and anti-bleeding effect only when the INR is between 3 or 3.5. If your INR is less than 2, there is a huge risk of thrombotic risk. And if the INR is more than 3 or 3.5, you can see there is a huge increase in the bleeding risk. If the INR is more than 3, you can see the 2 times bleeding risk. As the INR comes down, there is a significant increase in thrombotic risk in the form of stroke, especially in patients with atrial fibrillation. So that is a problem with the vitamin K antagonist. So you cannot have a low dose or you cannot have a high dose. And this therapeutic window is so narrow. That's why you have to do frequent dose adjustments. So that's why the TOSACs have come in. So the advantages of TOSACs or vitamin K antagonists are they are rapid onset and offset. So they act immediately. If you stop the drug today, the action is gone tomorrow. And predictable pharmacokinetics, there is a fixed dosing and there is no need for routine monitoring. There is no food or drug-to-drug interactions. They have a better safety profile and they reduce intracerebral hemorrhage by 50%. And they are either non-inferior or sometimes it is superior in preventing thrombotic complications such as stroke. That's why in many of the situations, we switch over to TOSACs from oral anticoagulants. Having decided what are TOSACs, why we have to use TOSACs, and which are the situations we must use TOSACs is the next question. So these are the indications for the anticoagulants: deep vein thrombosis, pulmonary embolism, myocardial infarction, unstable angina, acute coronary syndrome. These are the acute coronary syndrome. Rheumatic heart disease with atrial fibrillation or a huge left atrium. Many cardiovascular disorders like stroke or embolic stroke and so on. And the defibrillation syndrome such as antiphospholipid syndrome and vascular surgery, prosthetic heart valves, and also retinal vessel thrombosis in patients with EEC, when extracorporeal circulation and hemodynamics, and sometimes in patients who have got the LV thrombus or LA thrombus. But important thing we have to understand is it is not as if TOSACs have replaced in all these situations the vitamin K antagonist. Vitamin K antagonists are still the drug of choice whenever the patient has got mechanical prosthetic valve or patient has got moderate to severe mitral stenosis with or without atrial fibrillation with a huge atrium, then it is only the vitamin K antagonist. And here the Tosacs are not used. When the patient has got mitral stenosis based the valvular disease or mechanical positive valve, it is still vitamin K antagonist. And of course, when the patient has got a bioprosthetic valve and the bioprosthetic valve is in mitral position, still we have to use the original vitamin K antagonist and not Tosacs. And of course, when the patient has got intracardiac thrombus, such as LV thrombus or LA thrombus, once again, there is no data for Tosacs. So these are the 3 or 4 situations we cannot use Tosacs instead of vitamin K antagonist. So as far as the atrial fibrillation is concerned, there are almost all the 3 or 4 Novacs, no longer they are called Novacs, Tosacs are recommended over warfarin, except the exceptions I have told you, like mitral stenosis and prosthetic heart valve. And you have to check the renal and hepatic function to choose an appropriate Tosac. And patients with a score of chance DS2 VAC score of more than 2 in men, equal or more than 2 in men, more than equal or more than 3 in men, qualify for patients if they are not mitral stenosis or prosthetic valve, qualify for Tosacs. And of course, there are now some antidotes when the Tosacs patient develop a bleeding, especially for dabigatran. So having decided where to use Tosacs and where we should not use Tosacs, now we come to the most important question of beyond atrial fibrillation, which are the situations we are going to use the Tosacs, especially what is its role in patients with a chronic coronary syndrome. So there are certain situations, as I told you, in atrial fibrillation, it is well known, and the treatment of DVT and pulmonary embolism, we can use Tosacs, and long-term prevention of recurrent DVT or pulmonary embolism, we can use Tosacs. And of course, in a post-major orthopedic surgery or major abdominal surgery, we can use Tosacs to prevent post-operative pulmonary embolism. And patients with the post-PCI patients with a concomitant atrial fibrillation also, we can use Tosacs. So these are some of the indications other than atrial fibrillation. The selection of Tosacs depends upon various situations. If the patient has got a high risk of bleeding, we've got a high bleeding score, it should be dabigatran or apixaban. If it is a gastrointestinal risk of bleeding, it is apixaban. And high ischemic stroke, low bleeding risk, it can be dabigatran. When the patient got a previous stroke, it is definitely rivaroxaban. When the patient has got coronary heart disease, all types of coronary heart disease, it should be rivaroxaban. Renal impairment, it would be apixaban, rivaroxaban. GA upset or disorders, better acceptable for GA tract will be once again rivaroxaban. And patient's preference, because it's a once a day, rivaroxaban is preferred whenever the patient has got. So these are the selection of Tosacs in atrial fibrillation according to the situation you have. So as I told you, there are many indications for oral anticoagulants. What we are going to concentrate today is what is the role of Tosac in chronic coronary heart disease. So for that, we must understand what is chronic coronary heart disease. So the coronary heart disease starts as the endothelial dysfunction. So endothelial dysfunction can be described in just 4 words. The endothelium becomes sticky, means it becomes it exposes the addition receptors and the cells like monocytes and also the platelets and also the LDL particles come and stick to it. It becomes leaky. After sticking to the endothelium, they go through the endothelial cells to the subintimal space. So it becomes leaky and it becomes sticky because there is a significant proliferation of smooth muscle cells. And because of increase in vasoconstrictors, when compared to vasodilators, they are vasoconstrictors and they become tiny. So the endothelial dysfunction is the first important step, where the endothelium becomes sticky, leaky, thicky, and tiny, starts the atherosclerotic processes. So once there is an accumulation of the foam cells, and the accumulation of foam cells convert the subintimal space into an atheroma. So once there is an atheroma formation where there is only accumulation of lipids, what happens is the smooth muscle cells in the media break the barrier between the intima and media and moves over into the intima, into the atheroma to form or convert that atheroma into a plaque. So the plaque may have very important 2 important constituents. One is the fibrous cap, another is the lipid core or apoptotic bodies or the dead cells, the lipid core, and it may also have a vasa varorum. So the behavior of this, the plaque is going to decide whether the patient is going to go for a chronic coronary syndrome or acute coronary syndrome. If this plaque is continued to grow as a hard plaque and it is not going to rupture and it is going to continue to grow as hard plaque and going to reduce the lumen of the blood vessels or coronary vessels, the patient will be having a chronic angina or a demand angina, what we call as an angina on exertion, or his treadmill test may be positive, or he may be completely asymptomatic with a positive stress test or positive perfusion abnormalities. So this is a chronic coronary syndrome where the patient may not develop an acute coronary syndrome and may have a chronic angina without developing acute coronary syndrome because the hard plaque is growing and occluding a portion of the lumen. So the blood flow through the intact lumen is adequate at rest and not adequate on exertion. Contrast to that, if a plaque, which is even a non-stenotic, and most often it's a non-stenotic plaque, which becomes vulnerable to rupture. A vulnerable plaque is the one which has got a large lipid core and a thin fibrous cap with a shear stress of blood flow across it. So whenever this type of plaque is there, a completely asymptomatic patient, suddenly, why it's an asymptomatic patient is, this is a non-stenotic plaque, which may not occlude a significant portion of the lumen. The plaque ruptures and the acutely fresh formed thrombus can produce either acute vascular event in the form of STEMI, non-STEMI, or acute limb ischemia, or acute stroke, and so on. So this is how the difference between an acute coronary syndrome and chronic coronary syndrome. Another subset of patients who have got a chronic coronary syndrome will be those patients after a certain time of acute coronary syndrome. They will have the stabilized plaque. The plaque which has ruptured becomes stabilized, but the plaque is there. So these are also come under chronic coronary syndrome patients. Most often previously, we called these patients a post-MI patient or a chronically chronic demand angina patient or a chronic stable angina patient as a chronic coronary, as a stable CAD. Why it is not stable? No longer they are stable, called stable CAD, because 1 in 4 will develop major adverse cardiac events in the first year, and in 1 in 5 once again will develop major adverse cardiac event within 4 years. So almost 20% of people within first year may develop a problem, or even after 4 years, 1 in 5 may develop a vascular problem, especially on the cardiovascular side. That's why the stable coronary heart disease is a myth, because we always believe that the stable coronary heart disease patients are stable, and we are continue to write the prescription. We continue to repeat the prescription of aspirin, statins, and so on, and without estimating the risk to develop a future problem. So it has been shown now, patients with atherosclerosis who've got the atherosclerosis in more than one vascular bed. That means they may have a coronary heart disease plus a carotid arterial disease, coronary heart disease plus a peripheral vascular disease, or patients with a heart failure with coronary heart disease, or patients with coronary heart disease with renal impairment, or those patients who are no longer stable because they have very high risk of developing future events. So that's why the stable coronary heart disease is no longer stable. So once again, even the patient did not develop a previous MI, even a patient with a chronic stable angina, what we call as a chronic stable angina, 1 in 8 will develop the stroke or myocardial infarction and die from cardiovascular causes within 4 years. So that's why now the stable coronary heart disease is renamed as chronic coronary syndrome by recent guideline 2019 by European Society of Cardiology. So what is chronic coronary syndromes? The chronic coronary syndrome will have 6 subset of patients. The 2 subset of patients are post-MI. So a patient who is completely stabilized within 1 year of post-MI or 1 year of recent revascularization like PCI, or patients after 1 year of initial diagnosis of AMI or ACS or revascularization. So these 2 groups are post-ACS patients, and patient with a chronic stable angina, or patient with a heart failure due to coronary heart disease, patient with a suspected vasospastic angina or a microvascular disease, or patient who are completely asymptomatic, but a positive treadmill test or a positive perfusion imaging, all the 6 group of these patients come under coronary heart disease patient. So these patients, when they have additional risk factors like other or a polyvascular problem, are at very high risk of developing the acute coronary syndrome and next acute coronary syndrome, stroke, or peripheral vascular disease. So most often we are very aggressive in first few weeks or first few months of post-ACS with use all sorts of antithrombotic drugs like thrombolysis and antithrombin drugs like heparins, and also the dual antiplatelet drugs, because the first few months after post-ACS, the thrombotic risk is very huge when compared to the bleeding risk. Whereas after a few months after an ACS, the thrombotic risk comes down and the bleeding risk is almost same or slightly high. That's why we take things easy after a few months of post-ACS, and we either switch over to single antiplatelet, and without estimating the risk of this particular patient to develop next cardiovascular event, we keep on repeating the prescription of most often a single antiplatelet and a mild dose of statin and so on. So that's why it is very, very important to realize that it is not only, it is important to prevent the thrombotic risk in acute coronary syndrome, it is also important to prevent the thrombotic risk in chronic coronary syndrome. So the problem is a delicate balance between the thrombosis and bleeding. In chronic coronary syndrome, so acute coronary syndrome, it is easy because thrombotic risk is more than the bleeding risk. Whereas in chronic coronary syndrome, we are always afraid of bleeding and we don't look at the thrombotic risk, and we significantly reduce the antithrombotic drugs so that the patient and subsequently the patients will end up with either ischemic syndrome in the brain, the heart, or the limbs. So that's why it is very, very important to balance the thrombotic risk and bleeding risk, so that in chronic coronary syndrome, we must prevent a future thrombosis without increasing the bleeding. So that's why it is a very delicate balance in managing a patient with chronic coronary syndrome. So that's why the very important statement from European Society of Cardiology is that these patients with the chronic coronary disease patients are only stable in relative terms, but not in absolute terms. And this is the kind of population that deserves and requires an additional therapy apart from a single antiplatelet therapy. And majority of these patients, we put them on a single antiplatelet therapy and just continue them without estimating the risk. So here in chronic coronary syndrome, it is not only prevent, it is not only always when the heart, we always concentrate on the heart. In a chronic coronary syndrome patient, we always concentrate to prevent next heart attack. But it is very important to realize many of the chronic coronary heart disease patients may develop a stroke, may develop acute limb ischemia or heart failure and die. Although you have protected from acute coronary syndrome, these patients may develop additional heart problem or additional vascular problem and die. So it is very, very important to remember the purpose of treatment in chronic coronary syndrome is not only preventing future acute coronary syndrome, but also preventing other vascular system problem and prevent muscle problem like heart failure. That's why when the patient has got a known cardiovascular disease, although we put the patient on statins, we always estimate the residual risk. The residual risk can be residual cholesterol risk in spite of statin, residual inflammatory risk in spite of statin, or residual thrombotic risk, or residual triglyceride risk, or residual LPA risk. What we are concerned is the residual thrombotic risk in a patient who has got a known cardiovascular disease, especially a chronic coronary syndrome. The residual thrombotic risk, we don't have a simple biomarker to assess that patient. And of course, in these patients, we must concentrate on increasing the antithrombotic drugs, such as dual antiplatelet drugs or an anticoagulant plus an antiplatelet drug, which is now called as dual pathway inhibitors. So we have to concentrate on all this residual risk in patients with chronic coronary syndrome. Our focus of attention today is concentrating on residual thrombotic risk. So for that, we must know why it is very important to block the two pathways. Whenever there is an endothelial injury here in patients with vascular problem, what happens is the von Willebrand factor is there, and von Willebrand receptor from the platelets first gets adhered to the vascular endothelium. Once the platelet get adhered to the vascular endothelium, it becomes activated, changes its shape, and releases a lot of platelet activators. And these platelet activators expose the activated 2B3A, GP2B3A, 3B3A receptors on their surface, and they combine with other platelets. So they combine with other platelets. And in addition to that, the coagulation system gets activated, as we have seen, through the intrinsic pathway. So through the intrinsic pathway, the thrombin is formed from 10A. The thrombin is formed. Thrombin is not only going to produce fibrin and stabilize the fibrin. So along with the platelet, fibrin also get involved in the thrombus formation. And the thrombin itself is going to further activate the platelets and produce more platelet aggregation. And the patient results in acute thrombus formation and develops an acute vascular event in the form of acute coronary syndrome or a stroke or acute limb ischemia. So it is very important. That's why now we realize it is so far in chronic coronary syndromes, we are concentrating only on the platelets. Either we are using single antiplatelet or dual antiplatelet drugs to block the platelet alone. So this is called dual antiplatelet therapy. But we must also concentrate to block the coagulation system by preventing the thrombin formation with an anticoagulant. So that's why now this new mode of approach is called dual pathway inhibition treatment. So it is dual pathway inhibitors will be an anticoagulant plus an antiplatelet is the one which will completely achieve the problem of preventing a thrombus. Because if you block the platelet alone, if the coagulation system gets activated, it is not enough to block the platelet alone. When the coagulation system gets activated and form a thrombin, and thrombin is going to convert the fibrinogen to fibrin. And once again, your antiplatelet drugs may not be effective because this thrombin is going to further activate your platelets. A thrombin is a powerful platelet activator. That's why we have to block the thrombin and block the platelet by the dual pathway inhibition. So the aims of the management of coronary syndrome will be, as I told you, to prevent next acute coronary syndrome and give symptom relief and reduce the mortality due to coronary heart disease itself. Second is to prevent a stroke in patients with the chronic coronary syndrome. And we also prevent acute limb ischemia or a peripheral vascular disease in patients with the chronic coronary syndrome. We have to protect the muscle and also prevent heart failure. And of course, the patient also through these medications, we should not endanger the kidney or produce a kidney problem. We have to also protect the kidney in patients with the chronic coronary syndrome. That's why it is not enough to prevent a coronary vascular event alone. We have to look beyond your coronary artery in chronic coronary syndrome so that the holistic prevention of the other vascular beds, the muscles and kidney are very, very important to reduce the mortality and morbidity due to acute coronary syndrome. So to do this, what we are going to do, whether we are going to continue dual antiplatelet drugs or we are going to do a dual alternate pathway inhibition, which is called DPI or DAPI, which involves the combination of an antiplatelet and an anticoagulant. So having understood the role of TOSACs beyond atrial fibrillation, especially in chronic coronary syndrome, now the very important factor to answer is, among these three target-specific oral anticoagulants, which oral anticoagulants we are going to use in chronic coronary syndrome, in which patients we are going to use dual antiplatelet drugs, in which situation we have to use the dual pathway inhibitors. And if you are going to use the dual pathway inhibitor, which will be the anticoagulant which is got an evidence base? So that is the next question to be answered. So now it is very clear in chronic coronary syndrome patients who are at high risk of ischemic event. What are the people who are high risk of ischemic event? People with a diffuse multivessel disease plus diabetes, recurrent myocardial infarction, peripheral arterial disease, or CKD with the eGFR less than 60 ml per minute. So in these high risk patients, we have to add second antithrombotic drug. It is not enough in this patient to give aspirin alone. Here you have to add a second antithrombotic drug. Even in patients with a moderate risk, which is defined as a multivessel diffuse CAD, diabetes, recurrent PAD, in addition to all this, we have heart failure and CKD here. So either in high risk patient or a moderate ischemic risk patient, we got to once again add a second antithrombotic drug. That's why in all patients with a chronic coronary syndrome, be it a stable coronary heart disease patient with a demand angina, or a patient with a post myocardial infarction, even 10 years or 15 years after post MI you are seeing, it is very, very important to risk stratify that patient. Whether that particular so-called stable CAD patient is a candidate of high risk ischemic event in future or moderately increased risk of event in future. The event may be not necessarily an acute coronary syndrome. It can be a stroke or an acute limb ischemia or heart failure. In this patient, you need second antithrombotic drug in addition to aspirin. Here you have two options. In the two options will be adding an additional antiplatelet drug to an aspirin or add an anticoagulant to an aspirin. So dual pathway inhibition or dual antiplatelet drugs. Today, with many trials, now we know in these high-risk ischemic patients, the high-risk chronic coronary disease patient, the second antiplatelet preferred will be ticagrelor to the tune of 60 milligram twice daily, along with the aspirin of 75 milligram, is the preferred secondary antiplatelet drug. So if you choose to use a dual antiplatelet drug, it will be aspirin plus ticagrelor of 60 milligram BD. So there are many trials which have shown that dual antiplatelet drugs in high risk or moderately increased risk patient definitely reduce major adverse cardiac events. So, but definitely they also increase the bleeding. But none of the dual antiplatelet drugs in these patients have or had reduced the mortality. So that's why these dual antiplatelet drugs are good enough to reduce the major adverse cardiac events with a different risk reduction. But of course, the bleeding is little more when we compare the other single antiplatelet drug. That's why dual antiplatelet drugs may reduce major coronary event, but not the death. So that's why people have thought about the using a dual alternate pathway inhibition like DPI, like combining an anticoagulant with an aspirin. So there are two trials, which is called Atlas ACS2 and Voyager trial, gave us a very important insight to use the dual pathway inhibitors in patients with a chronic coronary syndrome. So because these two trials are in two different subsets of patients. So Atlas ACS in patients with acute coronary syndrome and Voyager is in patients with the peripheral arterial disease. In peripheral arterial disease patients, especially when they have undergone a peripheral revascularization for a significant peripheral arterial disease, post-peripheral revascularization, if rivaroxaban of 2.5 milligram twice daily is added with an aspirin and it is compared with aspirin alone, there is a significant decrease in the major outcome of cardiovascular death, acute limb ischemia, major amputation and stroke, and the major bleeding is slightly increased, and ICH major bleeding is also increased. So this gave us some idea. This is purely in a patient with a peripheral arterial disease. If you are using anticoagulant plus an aspirin, of course, bleeding is a little higher, but definitely they are going to reduce future event, not only on the peripheral arterial side. Please remember, these patients are peripheral arterial disease patient. Not only the peripheral arterial disease event are going to be reduced, but also it is a cardiovascular event, MI and stroke. So that's why they have tried this combination in post-ACS patient. What happens in post-ACS patient when you try rivaroxaban plus an aspirin instead of dual antiplatelet drugs? And this is the trial, Atlas ACS2 trial. So here the aspirin, the rivaroxaban is added either with a single antiplatelet or with a dual antiplatelet. In some patients, dual antiplatelet plus rivaroxaban, or a patient with a single antiplatelet with rivaroxaban, post-ACS patient within a week. When you add, once again, you can see they have significantly reduced the primary endpoints of cardiovascular death, MI and stroke. But once again, there is a significant increase in the fatal as well as the major bleeding. So this is some idea we got that the addition of rivaroxaban plus an aspirin, we can try in chronic coronary syndrome. So this is a trial which tried that. So what happens when you give, instead of a dual antiplatelet drug, a dual antiplatelet drug, you combine a rivaroxaban of 2.5 milligram twice daily with an aspirin of 100, or you try only aspirin alone, or you try rivaroxaban alone in whose patients, in chronic CAD patients or a chronic peripheral arterial disease. Very, very huge trial. It's called COMPASS trial, and it involved more than 20,000 patients. And the inclusion criteria: patient must have coronary or peripheral arterial disease, established coronary or peripheral arterial disease. So patient with the peripheral arterial disease, no other criteria is needed. But in the patient with the coronary artery disease, that must be either above, equal or above 65. And patient with the coronary artery disease, if they are less than 65, they must have undergone revascularization or must have an atherosclerosis in 2 vascular beds. That means in addition to coronary artery disease, they must have a cerebrovascular disease, or they must have peripheral vascular disease. Or if they are less than 65 plus CAD, they must have additional 2 risk factors such as diabetes or lipids or obesity or smoking and so on. So these are in these patients, and they have tried the combination of rivaroxaban 2.5 milligram BD plus an aspirin of 100 milligram versus the aspirin alone. So this is the trial. So this is how, see, for example, in this COMPASS trial, the patient, what we say as a placebo patient, when they compare with the rivaroxaban, we say placebo patient. The placebo patients are not as if they are not receiving any drugs. All these placebo patients are well protected by the statins, ACE inhibitors, beta blockers, and aspirin. So they are all well protected population. They are already stable and they are well protected population. In this population, we are going to add a rivaroxaban to see whether there is an additional reduction in the vascular disease reduction. So that's why you must understand what we are going to call a placebo is not a patient without any drugs. They are well protected patients with all sorts of protective agents today, with a statin, ACE inhibitor, beta blocker, and they are already on a single antiplatelet drug. So in these patients, which I told you, these are the patient, non-PAD patient or coronary patient, either coronary patient above 65 or a coronary patient less than 65 with additional vascular involvement or multiple risk factors. In these patients who are well protected with all these drugs, we are going to add rivaroxaban 2.5 milligram BD with an aspirin, and this is the result. So this is the overall result of a primary outcome result. Primary outcome includes CV death, stroke, and myocardial infarction. So the overall, the composite endpoint is significantly reduced. As you can see, the red bars are aspirin and the black bars are rivaroxaban and aspirin. And most importantly, in contrast to dual antiplatelet drugs, the cardiovascular death is significantly reduced, almost 22% reduction in the cardiovascular death. The most important outcome here, you are using this drug combination in a patient who's got a coronary heart disease above 65 or coronary heart disease with less than 65 with additional vascular bed involvement or multiple risk factors. So this is what is a very, very important to realize. In these patients, you not only reduce cardiovascular death, you are 42% reduction in stroke. So many patients with the coronary heart disease syndrome, a chronic coronary heart disease patient, many times you will be treating as coronary heart disease, and immediately or sometimes what you can find will be these patients will be landing up with a stroke and becomes, as I showed you, one of the patient with a stable CAD landing with a stroke. So we lose the patient or we lose the quality of the life of the patient with a stroke. So there is a 42% reduction in stroke. And of course, myocardial infarction is also reduced to the tune of 14%. So it is not only composite endpoint, the individual components of the composite endpoints. Many times in many trials, the composite endpoint may be driven by not a most important factor like death. It will be driven by a factor like a post-trial reduction in myocardial infarction. Here, the death is reduced, stroke is reduced, and myocardial infarction is reduced. So all the 3 endpoints are reduced. So this is the patient with a chronic CAD or PAD in COMPASS trial, almost 27,000 patients. And you can see the rivaroxaban plus aspirin have the best reduction in composite endpoint of stroke, death, and myocardial infarction when compared to rivaroxaban alone or an aspirin alone. So with a significant p-value. And of course, what is very important to realize, they not only reduce myocardial infarction, they not only reduce death, they also reduce composite endpoint. And the most important point is significant reduction in stroke. They also reduce what is known as a major adverse limb event. They also protected the peripheral vessels. So they protected the brain, they protected the heart, they protected the limb, and they reduce, we can see the significant reduction in amputation. And the net clinical benefit is always favors the combination of rivaroxaban and aspirin. So the problem is bleeding. Once again, so there is some increase in bleeding, especially the symptomatic bleeding, not a fatal bleeding. So the bleeding is increased, but you can see the bleeding is not progressively increasing. The bleeding is almost stationary between 12 months and 30 months. There is a reduction in myocardial infarction. There is a significant reduction in stroke. You can see that light blue bars. There is a significant reduction in stroke, and there is a significant reduction in cardiovascular death. So this is the safety, and this is the efficacy. So definitely the efficacy is much more than the safety of bleeding. So that's why it is very important to realize the stroke reduction. So most often we think that these agents, when we combine an anticoagulant and aspirin, we believe that they will always reduce ischemic stroke. So definitely they have reduced the ischemic stroke, as you can see that here. The rivaroxaban and aspirin, the blue line, have significantly reduced ischemic stroke, and they also reduce significantly the hemorrhagic stroke, almost equal to aspirin. So very surprisingly, you can see the hemorrhagic stroke is reduced and ischemic stroke is also reduced when you use this anticoagulant. The most important benefit of this anticoagulant plus an aspirin when compared to dual antiplatelet drug will be reduction of mortality. So as I told you, none of the trial with the dual antiplatelet drugs had reduced the mortality. There is a cardiovascular mortality is reduced by 18% with a significant p-value. So of course, we must look at the bleeding. So the modified ISTH bleeding and conventional ISTH bleeding is Interstitial Society of Hemorrhage, thoracic hemorrhage is definitely increased with rivaroxaban plus an aspirin. So definitely the bleeding is increased. That's why you have to choose the patient, and definitely not a fatal bleeding. So fatal bleeding is not increased. So now we are going to look at the net clinical benefit. We have increase in bleeding, we have decrease in ischemic events on all the three vascular beds. If you look at carefully, for the first 6 months or first 9 months, the increase in bleeding has happened, but this increase in bleeding did not progressively increased. That is a very important point. It is not progressively increasing. It becomes stationary. For that matter, the patient did not develop a bleeding in the first 6 to 9 months, is unlikely to develop bleeding in the next 36 months of this particular trial's duration. Whereas look at this efficacy point, there is a significant progressive decrease in your cardiovascular death, stroke, and myocardial infarction. So your thrombotic risk is progressively coming down through the duration of the trial, but the increase in bleeding is not progressively increasing. That's why the net clinical benefit is much more than the bleeding risk of this combination. So that's why it is very, very important to realize this very important curves to tell you that the bleeding risk remains stationary, whereas the reduction in thrombotic risk is progressively decreased over the course of years. So that's why when we compare the drugs which are providing the cardiovascular benefit today, such as SH2 inhibitors, the lipid-lowering drugs like the statins and PCSK9 inhibitors, and BP-lowering drugs such as the beta blockers, AC inhibitors, and so on, when this combination, rivaroxaban and aspirin, has got the maximum benefit in reduction of major adverse cardiovascular event, and they reduce death. Of course, the SGLT2 inhibitor had greater benefit in reducing death when compared to the rivaroxaban and aspirin. But as far as the stroke is concerned, the combination wins hands down when compared to all the other therapies. So that's why this combination is the best to reduce a stroke in a patient with a chronic coronary heart disease or a chronic PAD patient. So that's why you can see that another important problem is heart failure. So once again, you put this patient, when this combination of patient was got heart failure, as you can see, heart failure with aspirin and heart failure with rivaroxaban plus aspirin. We can see the difference here. When you put the patient on heart failure in this combination, there is a significant reduction in future adverse events. So even heart failure patient with coronary heart disease or a PAD patient, the switching over from a single antiplatelet. What is our mindset when the patient has got a heart failure? We keep on concentrating on heart failure by giving RNA, by giving a SLJ inhibitor. Our mindset is to prevent next heart failure. But this heart failure patient may land up with acute coronary syndrome again, land up with a stroke again, may land up with a peripheral vascular disease again. So even the patient has got a heart failure, this combination definitely prevents the future vascular event in a patient with a heart failure. So that's a very important point to be recognized. So when this trial, the outcomes of COMPASS trial is, it reduces CV death, the composite endpoint, by 25%, and ischemic stroke by 50%, and mortality by about 20%. So the net clinical benefits are going to be more and more during the course of treatment, whereas the bleeding risk is going to be stationary. The greatest benefit will be patient with a polyvascular disease, that is an atherosclerosis in two vascular beds, heart failure patients, CKD patients, and diabetic patients. So that's why the dual pathway inhibition becomes a very highly attractive option for the long-term managements of chronic coronary syndrome. So that's why if you look at the two important trials, which looked at the dual antiplatelet drugs with a diabetes plus stable coronary heart disease patient or a post-ACS patient, you can see that ticagrelor, I told you, ticagrelor plus an aspirin, or when compared that with the dual pathway inhibition with the rivaroxaban plus aspirin versus an aspirin. So when you compare this, what is important to realize is that all the dual antiplatelet drugs have reduced the major adverse cardiac events, and the major adverse cardiac events is greater in the patients who received the dual pathway inhibition with rivaroxaban and aspirin. And the bleeding remains almost same. You can say even it is less when compared to the dual pathway inhibition. The most important point here is the stroke reduction is greatest when you use rivaroxaban and aspirin. But most important thing you have to understand, there is no mortality benefit in dual antiplatelet drugs, whereas a significant reduction in mortality with the dual pathway inhibition. So this is how we must understand the differences between dual pathway inhibition and also dual antiplatelet drugs. So that's why now the guideline recommendation is not only the rivaroxaban plus aspirin in patient with the post-ACS, even without atrial fibrillation. So that's what I named this lecture as Beyond AF. And also patient with a stable CAD without AF. The standard dose of rivaroxaban 2.5 milligram BD with an aspirin of 75 to 100 milligram per day is going to give you greater benefit. To give you some summaries and takeaways, then, so what is very important to understand, we have to risk stratify a patient who are likely to be what is known as the stable CAD. No longer they are stable. They are called chronic coronary disease, chronic coronary syndrome patients. So please risk stratify these patients. What are the high risk patients? Multi-vessel disease patients, plus diabetes, recurrent MI, PAD, or EGFR less than 60. Or a moderate risk. Moderate risk is addition of heart failure. Addition of heart failure and EGFR is a moderate risk multi-vessel disease. So these are the 6 factors. So either a high CV risk patient or moderate risk patient the single antiplatelet drug is not enough. Either you have to do a dual antiplatelet drugs or dual pathway inhibition. So how to decide whether it is dual antiplatelet or DPI? What are the differences between these two trials? And dual antiplatelet drugs have excluded stroke. So we do not know whether the dual antiplatelet drugs will prevent future stroke. And the dual antiplatelet drugs are tried in many trials only after 3 years of post-MI. Whereas in COMPASS trial, people are included even after 20 years of post-MI. And of course, this dual antiplatelet drugs have reduced MACE, but not the mortality. Whereas COMPASS reduced the mortality. So that's why you can see when you look at the meta-analysis of dual pathway inhibition versus DAPT, what I want you to concentrate is reduction of cardiovascular death and also the reduction of stroke, significant reduction of stroke, and there is no significant increase in bleeding, and there is a significant reduction in mortality. So these are the points we must realize in patients with the chronic coronary syndrome patients. First important point to risk stratify patient and then select in a particular patient whether I should use a dual antiplatelet drug or dual pathway inhibition. The advantage of dual pathway inhibition is not only on the cardiac side, but also in the brain side, but also in the peripheral vascular side, but also on the mortality side. And of course, there is no significant increase in bleeding when we compare with the dual antiplatelet drugs. That's why dual alternate pathway inhibition should be considered in a stable CAD patient when they have multivessel disease, when they have coronary heart disease with a peripheral artery disease, or patient with a pure peripheral artery disease. In a pure peripheral artery disease, we don't look at the heart at all. But in a pure peripheral artery disease patient, most often patient will die of a myocardial infarction or a stroke. So you have to prevent brain and heart in a patient with a peripheral artery disease. And of course, after 12 months of DAPT in post-ACS patients, also when we risk stratify, we have to put the patient on dual pathway inhibition. So this is my final slide, which will give the complete summary and recommendation on after post-MI or CCS. So first, in a chronic coronary disease patient or post-MI, after 12 months who is completing or 6 months who is completing dual antiplatelet drug, post-MI after 6 to 12 months, or a chronic CCS patient, consider whether he is high risk of bleeding or high risk of thrombotic event. The factors which will increase the bleeding risk in this particular patient will be history of previous bleeding, bleeding disorders, anemia, thrombocytopenia, severe liver disease, AV malformation, cancer, extreme old age, frailty, and also already patient is on oral anticoagulation. These are the patients who are high risk of bleeding. So when the patient is in chronic coronary syndrome, our patient is completing dual antiplatelet drug post-ACS, if the patient has got the high risk of bleeding, then it will be only single antiplatelet drug with either of aspirin of 150 milligram per day, and the patient is not tolerating, then it is clopidogrel of 75 milligram per day. If the patient has got no bleeding risk, consider the high thrombotic risk. The high thrombotic risk is going to be peripheral arterial disease, multivessel CAD, and one or more markers of high risk we have told you, diabetes, CKD, and the recurrent MI, and patient with a heart failure. So these patients are having high thrombotic risk. When these patients have no bleeding risk, no high thrombotic risk, then single antiplatelet drug may be enough. So these patients do not have the high bleeding risk, but they have high thrombotic risk by means of these factors. Then you have to decide whether you are going to give dual antiplatelet or dual pathway inhibition. If the patient has got polyvascular problem in the form of peripheral artery disease, definitely dual pathway inhibition. Or the patient has got a previous history of stroke, definitely dual pathway inhibition, the rivaroxaban plus an aspirin. So in these two groups, it is definitely rivaroxaban plus an aspirin. The patient does not have previous history of stroke, or the patient does not have a polyvascular problem, but he has got high thrombotic risk. You can choose either DAPT or DPI. But please remember, when you use DAPT, if the patient is prone for stroke, he may not have a stroke. If the patient is high risk for stroke, such as a carotid bruit, or patient has got AB index, abnormal AB index. So even this patient may not have other vascular system problem, but he is prone for other vascular system disease, then it is better to select DPI. Otherwise, you can see it's a purely, if you are very sure, it is a purely a coronary heart disease patient. You have the option of selecting the DAPT with a ticagrelor of 60 milligram BD plus an aspirin, or rivaroxaban 2.5 milligram BD plus an aspirin. So in this patient, it is individualized. So when the patient does not have a bleeding risk and the thrombotic risk, it is single antiplatelet. When the patient has got a high bleeding risk, it is a single antiplatelet. When the patient has got no bleeding risk, but high thrombotic risk, definitely when the patient has got a stroke or a polyvascular problem, it is dual pathway inhibition. And of course, in other patients, it is an individualization between dual antiplatelet and dual pathway inhibition. So now we look at this scenario. So this is the patient post-MI 10 years developed a stroke. And this patient stable CAD with multiple risk factor developed acute coronary syndrome. So this patient post-MI PAD had acute limb ischemia. In all these patients, we can prevent these terrible events by actually starting these patients on dual alternate pathway inhibition like rivaroxaban plus an aspirin. So the word of caution will be, whenever you use the novel or no longer they are novel TOSACs, the target-oriented anticoagulant, always think of A, B, C, D, and E. A, abnormally low weight patient, you must reduce the anticoagulant dose, and it's preferred not to use very strong dose of antithrombotic therapy here. Consider the bleeding risk, especially the GI bleeding, and look at the creatinine clearance. And people who have got very low creatinine clearance, it is very, very important to realize that you have to use certain TOSACs and not all the TOSACs. And always remember the drug interactions, especially with the dabigatran. And in elderly age, definitely you have to be very careful when you are using strong antithrombotic agent. So this is a word of caution regarding the use of the TOSACs. And of course, when we look at the present scenario, the past is warfarin. So the past is warfarin in many of the situations. So still warfarin should be used in mitral valve disease patients and prosthetic valve patients and intracardiac thrombus and so on. The present is dual pathway inhibition with TOSACs, especially rivaroxaban. And today we are looking at the TOSACs beyond the atrial fibrillation in patients with a chronic coronary syndrome. We have very good trial evidence which reduce coronary events, stroke, peripheral arterial disease, as well as the mortality. And of course, we look for future indications for TOSACs, especially in patients with a mitral valve disease with atrial fibrillation, in mechanical valves, in further patients with acute coronary syndromes and other cardiovascular diseases. But important thing about the TOSACs is the cost. Once again, we look at the future where the cost may come down, and there are trials where we can use those conditions where we cannot use these drugs now, whether we will have an indication to use those drugs here, because they have an advantage of the safety, and they have advantage of no monitoring, they have advantage of no food interaction, they have the advantage of no drug-to-drug interaction. So that's what we look at the future regarding these wonderful drugs known as TOSACs. Thank you for your patient listen.
Sir, thank you so much for such an enlightening talk. Even I was mesmerized by some of the slides you shared. Sir, will we be taking any questions?
Yes, yes, please.
Okay. Sir, we have received a couple of questions regarding the use of TOSACs or NOACs, as you said, in COVID-19. So post-COVID, what do you feel is the usage?
Yes, yes, this is a very important question. So from my colleagues, I understand the myocardial infarctions which have happened during COVID had high thrombotic risk. They tell me that when they do a coronary angiogram, the thrombus burden is much more than the plaque burden. If you look at the classical acute coronary syndrome, you will have the plaque component and the thrombus component. And here in the COVID, they say it is predominantly thrombus. They have to keep on aspirating the thrombus. So that's what in one of the meetings we have suggested that, the post PCI AF patients, for first few weeks, we put them on all the three, dual antiplatelet plus an oral anticoagulant. Okay. So that type of protocol, I think there are no guidelines, but what I suggest will be a patient who has got high thrombotic risk like COVID, and it should be, I think, an addition of oral anticoagulant along with the dual antiplatelet may be necessary in these patients who have got high thrombotic risk. What I'm trying to say is people who have developed ACS and they have undergone a PCI or a thrombolytic therapy, post-COVID ACS, I think addition of anticoagulant along with standard dual antiplatelet drug is, I think it will be very, very useful to prevent a future thrombotic event or future ACS event.
I think even sir, a lot of doctors have used enoxaparin, their injectable, where patient is in.
They routinely use. They routinely use and use only anticoagulant. Okay. So you see, they are using only anticoagulant for 1 or 2 months and stop it. But if the patient has developed an event for ACS during COVID, so these patients should be followed up. They should be following up these patients with all these three drugs.
Right. Sir, one more question that we have got regarding the comparison of Pegasus and Compass. So, do you feel like there is a clear-cut guideline where to use a ticagrelor and where to use a rivaroxaban 2.5 BID? So, comparison questions have come.
So that's why I told you the Pegasus trial, as I showed you in one of the trials, yes, I looked at patients only around post-MI 3 years. One, they have not looked at the stroke and the mortality. So these are the three advantages with the Compass. So right, if your coronary heart disease patient is, let's say, 10 years old, okay, and he's got high risk factors, I told you, high risk of diabetes, CKD, or GGFR reduced, diabetes, multivessel disease, PAD, heart failure. He's 10 years post-MI. Okay. The evidence only for Compass. Okay. Right. One. Second, for example, this patient had a TIA. Patient post-MI or post-CS or a stable CAD. He had a TIA, one episode of TIA. This patient is prone for stroke. Okay. Then definitely DPI. Right. Definitely DPI. In your clinical examination, you have a carotid stenosis, carotid bruit. You routinely do an ABI. He's got a peripheral vascular disease. Right. AB index is abnormal. He's got a carotid bruit. That means he's got a polyvascular problem. Right. Then once again DPI, right, dual pathway inhibition. Okay. So excluding this, you can use dual anti. That's what Pegasus did. The Pegasus primarily looked at coronary event, whether the DAPT will reduce coronary event. Whereas Compass looked at whether the dual pathway inhibition will reduce death, stroke, coronary event, and peripheral vascular problem. Okay. So that's why the polyvascular approach for a Compass is a single vascular approach in DAPT trials. Right, sir. Right. So I think polyvascular, that is clear. Polyvascular disease is there. You should look for rivaroxaban plus aspirin. Exactly. Right, sir. Thank you so much, sir. I think we have had an audience of more than 80 doctors that were attending and listening to us. So thank you so much, sir, for your valuable time, and we really appreciate you your contribution in coming out today and discussing such important concepts in the field of anticoagulants. Thank you so much, and best wishes from Curis Mankind, sir. Thank you. Good night. Thank you. Good night. Thank you, sir. Good night, sir.